Okay, well, I want to welcome everybody online and in person to the last of our 6 series session on aging and elder care planning. This is the third year we've done this with Pierce County ADRC, and it's been a terrific class to be able to present to people. Matt and I both come with a lot of personal experience working with both of our sets of parents with aging and all the things that go along with it. And my name is Jen Kelly, and I'm a lieutenant paramedic with East Pierce Fire and Rescue. I've been in emergency services now for about 24 years. Have dealt with a lot of 911 calls where hospice and palliative care have been very confusing. So it's wonderful that we have an opportunity like this to bring this education to the public. I'd like to introduce Matt Santelli, community outreach and education specialist with Pierce County Aging and Disability. And without further ado, Matt, will have you take it away. Thanks.
Thank you so much, Jen. And yes, we're here to educate you and ask questions as we go along. So I'll stop every couple of slides to give folks in the room an opportunity to ask questions or make comments. And then it'll give us an opportunity for the folks tuning in remotely to do the same thing. So my name is Matt Santelli. I do work at the County Aging and Disability Resource Center. Those of you in the room, I hand out our brochure or kiosk card on family caregiver support. The handout for the actual PowerPoint also has some resource information on the last page. So if you're in a situation where you in your family are having someone come on to hospice care, you need some family caregiver support in terms of a professional agency coming in and giving you some relief, we can help with that through our family caregiver support program. So please pass the word on that. This might not be a current experience of yours, but you might know someone in the family or in your faith community that's facing an end-of-life situation and trying to figure out care for that person at home. And we can certainly help out with that here in Pierce County. So we call this one of our hot topic series because there are changes and evolutions that go with palliative care and hospice, and we'll touch on some of those today. And certainly feel free if you've had an experience that seems a little different or was something of a variation of what I'm describing, please feel free to raise your hand, comment on that, because this really is a collaborative, interactive presentation, and we want to hear more what's actually people's experience in the community when it comes to hospice and palliative care. So my contact phone number, 798-4600, and pierceadrc.org is our website. We have resources A to Z page on there. We have different event pages for upcoming events and things. Plus, you can always email or call. Our email address, I believe, is at the end and also on the kiosk cards there. I do a monthly newsletter that has happenings, local services, current topics, Social Security updates, Medicare updates, all kinds of different things that you can get free of charge through email on the 1st or 2nd of every month. So if you call or email us at the address that's on the kiosk card, I'll go ahead and get you on the newsletter. Get that from me every month. And you may even contact me then if once you're on the newsletter to say, hey, there's an event going on in our community, add that to the newsletter. We're always trying to focus on events that are serving our senior and disabled residents of Pierce County, keep them healthy, safe, financially stable at home as long as possible. The disclaimer that I'll give here is that we're not recommending any specific healthcare management plan for individuals. This is a talk generally about the benefit when it comes to hospice care and palliative care and what it provides for. This is not considered an exhaustive review of every possible situation that's come up in hospice care. Agency by agency who provide that service, there can be some variation in my experience. We're always recommending you talk with your physician to determine the best plan of care for you, your loved ones, whoever might be involved in an end-of-life situation. Okay, so some of the topics we'll hit. We'll talk about what exactly is end-of-life care and what palliative care includes, as well as hospice care. We'll talk a little bit about Medicare covering hospice care. Most of our clientele leans into that Medicare world. Not everybody, but most of them do. There can be end-of-life situations for people that aren't older adults, certainly, but many of the situations we deal with families we serve in that older adult world. Also talk a little bit about payment, how Medicare pays, Medicaid pays, commercial insurance, veterans coverage, what legal documents you should think about having in place to plan for end-of-life care, and additional resources that are available. Okay, so end-of-life care, that's the term we use to describe support in medical care given the time surrounding death. And we've really developed a better system to help people in those situations. And we always want to remind people that the support is there to provide comfort to a person who's ill in that end of life situation, but also to provide additional benefits and services to the families that might be caring for someone in that hospice situation. Because it can get very confusing with regards to end of life development, how the body reacts to end of life situation, the spiritual aspects about it, all those different things that go on. This type of care does not only happen in the moments before breathing ceases and the heart stops. Older people often live with one or more chronic illnesses and need significant cares for days, weeks, and even months before death. So in terms of our own experience, my parents, my dad went on and off hospice a few times. My mother-in-law, I think, went on and off hospice for years. I think it was 3 years total. And then palliative care, people have to remember too, is something that helps folks even not in an end of life situation. So we'll talk about the differences there, palliative care versus hospice care, ongoing treatment, but versus ending treatment, and how that differs from palliative to hospice care. End of life can look different depending upon the person's preferences, needs, and choices. Some people may want to be at home, others may need to be in a care facility. Kind of just depends on the family support as well. So some agencies might say that they do not serve individuals at home in hospice services. And that's because they're concerned about the support that person might be given. Now, if the situation is where there's somebody living in or coming there frequently, then that might change the dynamic a little bit. In my parents' situation, both my mom and dad, my mother-in-law and my father-in-law, they were all in care facility settings on hospice care. And I don't know what your family experience.
At home, but with family there all the time.
Yeah.
We did have one individual that was a high utilizer at 911 that rented a room in a home. It was a pretty difficult situation, but it was multi-care home and hospice, and they had a lot of support that came in and but there are some unusual circumstances where someone could be relatively alone at home, but.
Yeah, I had an older woman in Lakewood. She was a widow of a veteran and came over from Germany after World War II. And so she was living alone at home, but her faith community had pretty much 24 hours. People, it was amazing how much support she got for several weeks at end of life. So that in that situation, we were able to set up hospice care for. When possible, there are steps you can take to increase the likelihood of a peaceful death for your loved one, follow their end of life wishes, and treat them with respect while dying. And that's really the goal here, is trying to find ways to make those end of life situations the most comfortable as possible. I think most of us, in our experience with family members, my own view, of course, is that I want my dying process to be as painless as possible. I think that breakthrough pain that people can experience in end of life is what we're really talking about, managing it. And there's a lot of medical interventions we can do for pain management in those end of life situations. So let me go forward. Any questions so far, comments? Is everything kind of following through from your own understanding of the situations? So understanding the need. Generally, people dying need care in 4 areas: physical comfort, mental and emotional needs, spiritual needs, and practical tasks. The family, the dying person needs support as well with practical tasks and emotional distress. So again, it's not just focusing on comfort care for the person, it's also helping the family on the journey through the dying process. And there's a lot of misconceptions that came up with my own family on things. One thing we just talked about, individuals living alone at home. There's a misconception that hospice care is going to provide actual home care for a person living at home, and that's not true. The benefit is limited on what it provides, with the focus on physical comfort being the main thing, in partnership with family or friends or faith community people supporting that person at home. So physical comfort, it can include strategies to manage pain, breathing problems, skin irritation, digestive problems, temperature sensitivity, and so on. Mental and emotional needs, can reassurances, family members are there caring for them, physical touch, soft light, relaxing music, calming fragrances. Spiritual needs can include finding meaning in one's life, ending disagreements with others, making peace with life circumstances. So one point I would reference, like on spiritual needs, my parents were born Catholic, raised Catholics, retained their Catholic faith in their old age. And one aspect of the Catholic faith is the anointing of the ill. And that's it's changed as the sacrament to be anointing. It's not supposed to mean that you're dying necessarily, you get anointed. It's anointing of the sick. So it was amazing to me when we family gathered and we had the priest come into the care facility. And my mom up to that point had pretty much been unconscious, even though her eyes had been open at times, she was not responsive. And it was amazing when the priest stood at the bedside and began the ritual, she actually kind of awakened and reached for his hand. It was just like, wow, this is really a powerful moment. So that's part of the spiritual aspect. It doesn't have to be formally a religious aspect, but just some spiritual view of what the end of life process is like, where that person might be headed following their death and things like that. And then practical tasks, personal hygiene for the dying person, household chores, paying bills, caring for pets, and so on, all those things. And we've all known people that were healthy, and then there's some issue that comes up. Diagnostically, it's determined that they're terminally ill. We've all known people that seemed like they were doing fine, maybe a little illness nagging, and all of a sudden they're in an end of life situation. So those aspects of it can be quite overwhelming for family. And so most hospice care, if not all, also includes a social work aspect, where there's a social worker that comes in and does a needs assessment to determine everything going on with the person's needs might be day to day to be comfortable at home. Okay, so palliative care versus hospice care. Palliative care is to improve quality of life for a person suffering from a serious illness such as heart failure, COPD, dementia, even cancer. Person still receives treatment for that condition. So let's take the view of a cancer person, cancer sufferer, going through a lot of pain through the illness itself and all the treatment that goes along with it. They stay in treatment. The palliative team supports that person in other ways, including treating fatigue, weakness that can develop from things like chemotherapy, also addressing anxiety, depression a person might experience resulting from their illness. Palliative care is appropriate for anyone with a serious illness, whether it's chronic, curable, or life-threatening. So we put palliative care in with the hospice care presentation because it is all about physical comfort and managing pain, okay? But the treatment team is the one working on this palliative care service for that person, okay? So the treatment is continuing. It's not an idea that the person is terminally ill based on the doctor's judgment and treatment ends for that terminal condition and then hospice care starts. This is a different modality of treatment. And any treatment team can manage the palliative care. So up and down with my dad at times, he was on palliative care because he was being treated for certain chronic conditions. Then there were a period that looked like he was in a dying situation where it became hospice care. And then he would recover, and then sometimes we would start treatment again to extend his life, and then it was palliative care again. So the modalities can go back and forth. Hospice care, on the other hand, provides comfort and family support for someone having been determined to have a terminal illness. Usually that means that the doctor has judged that the person has 6 months or less to live. So this is the point where the doctor has looked at the condition and say, this is a terminal condition which will end your life within 6 months. Key difference from palliative care is that in hospice care, the person does not receive curative treatment for that terminal condition any longer. So if we go back to that cancer situation, say it's an advancing brain cancer that's inoperable, continues to evolve even with treatment, then that family member, and in talking with that individual with that condition, they may decide the treatment's too much, it's overwhelming, it's not going to help, it's not going to turn this disease around. So we're going to stop that brain treatment, whatever it might be, chemo, radiation, and we're going to move to a hospice care setting. So the hospice care setting means that person is no longer being treated, no longer wants treatment for that terminal condition that's going to end their life, okay? Person still gets medical care for other symptoms related to their disease, nausea, digestive problems, headaches, whatever the case that may be, as well as other types of support such as counseling, help with medical equipment, and grief support. Very specific eligibility though, the person must be diagnosed as having 6 months or less to live, must no longer pursue curative care. Person may choose hospice because they are no longer receiving the benefit from treatment, or they simply do not want to be treated any longer. So this last sentence is key when I think of my uncle. He had already lost his wife and daughter. He was living in an assisted living facility with renal failure. He was getting a dialysis treatment every week. And then at one point, he finally told my dad, I'm done. I want to join them. I don't want to maintain this dialysis treatment. So he had been on palliative care for comfort. Once he went off his dialysis treatment, he was in a terminal condition, because that's generally going to mean within a few weeks you're going to die with your kidney failure. And so then he became onto hospice care. So that's a stark example of the difference there. Palliative care because he being treated for renal failure with dialysis. Hospice care because he says, I'm done, I'm terminally ill, I don't want to continue this treatment, I just want to peacefully and comfortably die. Any questions or comments on that?
I can share another example with my stepmom. She ended up diagnosed with metastatic non-small cell carcinoma in her lung. And it metastasized to her bone and really was a shock, the diagnosis. She was in a lot of pain, and that was what led to the diagnostic tests that found the cancer. So part of Virginia Mason, so they kind of have that team approach to medicine anyway, but she ended up in the hospital. Because her pain was so significant, they brought the palliative team on board, but she was still working with the cancer doctor because while it was a terminal cancer, they didn't know if she'd have a year, 2 years, 4 months, whatever. And so they were sort of working in conjunction with each other to explore cancer treatments. She was still doing radiology, radiation, and also looking at starting chemo. The chemo, she had one session of chemo and the symptoms were so bad that they decided to discontinue that. But again, still sort of looking at, okay, not necessarily done looking at ways to potentially treat the cancer. While they knew they weren't going to cure it, they wanted to try and maximize life as long as possible. And palliative care trying to manage that pain. So kind of doing a holistic treatment of her when it became clear that it was too difficult to manage her pain any longer and her condition was deteriorating and the metastasis was actually worsening right before our eyes. The decision was made to transition to hospice, where now the entire focus was on keeping her as comfortable as possible until she died. And literally she died about 4 days after transitioning from palliative care to hospice. So kind of an example of how the systems can work together and then you can transition from one to the other when that time is determined to be appropriate.
Absolutely, yeah, and it's patient and family directed care. So giving that example, my uncle again, if a weekend do it, he had decided, there's something more for me to live for. And it started on dialysis again. Now his condition might have spoken against that, but say he did. Then hospice care ends and he's back on palliative care. So this is the other misconception I think a lot of people have. Well, once that diagnosis comes in and I start on hospice care, that's the end of it, Not necessarily, because like I said, with my mom and dad on and off a couple of times, my mother-in-law, the art of determining end of life is much more an art than a science, I always tell people. So doctors will say it's a 6-month terminal condition and people will live years beyond that 6 months. So it's just because it's always kind of a determination the doctor's making for what they're seeing and their experiences with a typical patient like that, but it's not determinative. Okay, so who provides the care? Like I mentioned before, palliative care provided by the current treatment team, which can include a doctor specializing in palliative medicines, might be a pain management specialist type doctor, nurse, pharmacist, social worker, dietitian, chaplain, volunteers. So this is all while that person's being treated. So no different than when like my uncle was on dialysis, he was still in a lot of pain for various conditions at his age. He was still getting palliative care to make him as comfortable as possible during that treatment period. And this wasn't any special services coming in. This was part of his current team that was treating his kidney failure through dialysis. Hospice care, also provided by a team, may include the hospice medical director, nurse case manager, social worker, bereavement counselor, home health aide, and hospice volunteer. Most home health agencies also offer hospice care. So home health is time-limited care following an illness or an injury where a person's rehabilitating. Physical therapy, occupational therapy, respiratory therapy. Often that home health service happens following a treated illness or injury in a hospital, not necessarily where the person's back at home, but they're just not quite well enough yet, but don't need to be in the hospital. You'd have a team of physical therapists come in, respiratory therapists, to rehab that person on a time-limited basis. Those same agencies often offer hospice care as well. So it's not unusual when you look it up, it's going to say ABC, home health services, and hospice care, because they're combined into. Most home health agencies do offer it. Most treatment providers for chronic life-threatening conditions offer palliative care. Physician orders are required to start both palliative care and hospice care. So these are doctor-directed orders based upon the medical necessity they're seeing for the need for comfort care. Okay, any questions on who does it, how it happens? Does Medicare pay for it? Medicare Part B, most commercial insurance, TRICARE, Veterans Health covers Medicaid, pay for some palliative care depending on the treatment. Medicare generally does not separate palliative care from the rest of a person's covered services. Palliative care provider will be paid like any doctor. So again, the example of my uncle, he was being treated by a kidney specialist, whatever the case might be. So that same doctor was managing palliative care, might have a consultant come in for certain pain management issues, might have a specialized nurse working with him. But it's doctors ordered with no separate team coming in. Medicare Part A, most commercial insurance, TRICARE, Veterans Health covers Medicaid, pay for hospice care. More details coming on the following slide. So one thing on Medicare, since we're in open enrollment period right now, I think something like 54% of everyone on Medicare is also in a Medicare Advantage plan. And an Advantage plan is basically a managed care plan that handles your Medicare benefit on behalf of Medicare. So if you're in a Kaiser Medicare Advantage plan, you're seeing Kaiser doctors, they're managing your care, they handle the billings and claims, okay? Even if you're on an Advantage plan, Medicare Part A, your original Medicare Part A, pays for your hospice care services. This confuses a lot of people, and I'm not sure why that anomaly is still there. Because we'll get calls from people on United Healthcare and Kaiser and say, oh my gosh, I lost my hospice care benefit. I called customer service and they say they don't pay for it. Well, they don't, because it's still paid by your original Medicare for your hospice care services. So confuses a lot of people, believe me. So when you look through your benefit booklet for an Advantage plan, hopefully there's a listing there that says hospice care not covered, but paid by your original Medicare. Okay.
You're gonna talk about 911 calls hospice.
Yeah, go ahead.
This often causes a lot of confusion, where people will say, I don't wanna call 911 because if I go to the hospital, I'm gonna lose my hospice benefits. There's a lot of confusion around that. And what I understand from hospice is that if somebody needs to be transported, so what I tell our providers when I teach this is if you're responding on a 911 call to a hospice patient that's on hospice for cancer, but they've fallen and broken their arm, please take them to the hospital and have that arm set or their pain managed if it needs to be outside what their hospice care services are. It's not going to cut them off of hospice because they're going to the hospital for a condition other than what they're already on hospice for. If they are on hospice for cancer and they've got a pain pump and now there's a problem with the pain pump, that may be more related to their hospice, what they're on hospice for. And so there may be some challenges in the emergency department. Again, if that's a more appropriate destination, we tell people not take them. We always encourage our providers to make sure they're contacting the hospice nurse or whoever the primary hospice contact is, based on what paperwork they're seeing at the scene, so that that's a very coordinated effort. Because even if they have to temporarily go off of hospice in terms of a payment issue when they're in the emergency department, that hospice coordinator can coordinate getting them right back on hospice when they go back home. So, you know, the mere presence of hospice shouldn't be a reason to not go to the emergency department. It just may need to be a coordinated effort. So that's kind of what I tell people. I really try to encourage people to make sure that they are communicating with hospice because they're the captain of the ship and need to be involved in making any decisions around that patient's care.
Exactly. There's a lot of misconceptions that go with that because people assume when a person goes on hospice care and everything stops. Not true. So for example, we have a friend of ours, friend of my wife's, lived out in Ocean Shore. She became ill. And so she was on hospice care at home. And back in the day when people had home phones, they would have you put like a green sticker on the phone cradle that says, call hospice first, don't call them. Her daughter was just having a fit. You know, oh my God, what if she rolls out of bed and breaks her arm? What's gonna happen? Is she just gonna die home? You know, it's like, no, like Jen was saying, the broken arm is causing her pain, so that will be managed. Okay, we don't know the extent of what the doctors decide to manage it in that end of life situation. But no, The rule has generally been call hospice first and they will direct you. And hospice is 24 hours, 7 days a week. They'll pick up that phone. So another example, my dad was in a skilled nursing facility in an end of life situation. And at the very end, he started to develop a fever. This was, as was explained to me, I'm not a nurse, but as it was explained to me by the hospice nurse, in an end of life situation, the body basically pulls blood flow and support to the torso. So the body temperature rises, even though the extremities might start being deprived of blood flow. So they might get cold. That's why people say I feel like I'm cold. Those end of life situations. The nursing facility called me and said, oh, he's got an infection of some kind. We want to treat him with antibiotics. And I was like, well, did you call hospice? Well, no, we're letting you know. I said, well, call hospice. And hospice nurse said, no, there's no treatable condition here. It's an end of life step that he's getting warmer because he's slowly end of life dying. Okay. So this is where hospice expertise really can help. Okay, so like I mentioned, Medicare pays for hospice care through original Medicare. It's covered pretty much at 100%. You might pay a co-payment of $5 for each prescription for outpatient drugs for pain symptom management. In a rare case, the hospice benefit doesn't cover your drug. They may contact to see your plan to see if Part D will cover it. This is all stuff the hospice providers should manage for you once the team's in place. They'll inform you of any drugs or services that aren't covered and if you'll be required to pay for them. You may pay 5% of the Medicare approved amount for inpatient respite care. So there is a part of the benefit where there can be a hospitalization that happens for various reasons. So, and I've heard different views on that from different agencies. So this is, again, something you want to have that discussion with that home health hospice provider before everything gets started. Your copay can exceed the inpatient hospital deductible for the year, will still pay for covered benefits for any health problems that aren't part of your terminal illness and related conditions. But this is unusual. Once you choose hospice care, your hospice benefit will usually cover all you need. In the situation like my dad was in the care facility and we were paying privately for him to be there, we still paid the private pay, but the hospice services were pretty much covered at 100%. Now, this whole issue here, we've heard different things when we've given this talk before. I know we had one lady that came in and said, well, her husband was suffering from dementia, but was terminally ill with other conditions and periodically would develop bladder infections because he'd get incontinent, he would want to change his underwear. Having those bladder infections would cause him to be more agitated with dementia. And as she reported it that day, I think as I recall, Jen, she was saying hospice told her, we're not going to treat that bladder infection. That didn't seem right to me. That seems to go against comfort care to me. So again, there may be some anomalies you might experience in your hospice services, and maybe she was misinterpreting what they were telling her. But in my view, anything that's producing discomfort should be managed by that hospice team, which could include an antibiotic in certain situations. So what's your experience with that since you've had specialties?
Anything, they can be on anything, they can make any decision they want.
Okay.
If you want to treat the bladder infection or not. I know that some places won't cover it. Ours did.
Okay.
Typically, but I just had a friend who, her husband was on hospice and they took away his insulin.
Oh.
I was mortified.
Yeah. Okay.
But maybe they won't pay for it, but she had a supply at home.
Yeah, okay, I got you. So maybe it was a benefit discussion versus a treatment discussion.
Exactly. A lot of it does come
Okay.
down to that
Got
whole
it.
insurance.
Okay, this is good to know.
aspect,
Good to know.
Which could be complicated.
Great.
But is there an appeal process where people don't necessarily, because I mean, with anything, not everybody knows everything there is to know about what we're talking about.
Yeah.
Right.
So is there an appeal process saying you might be doing this for 20, 30 years, but things like I know being within the state, things do change, the processes change and requirements change. So is there a process to appeal that decision? You say, well, I don't necessarily agree with what you're saying, or maybe I do agree with part of it, but I still kind of have more questions regarding this. Is there a process for that?
Can I say back up before you go on hospice or palliative care, take your review? There are different agencies out there, and this one says no medication. According to the government, I don't know whether it's government, I don't know which agency makes the rules. But you are supposed to get medication that makes you comfortable. Some interpret that as all medications, we paid for pretty much everything except maybe the chemo and radiation. Other organizations say only if it's relevant to your particular disease state. So if you're not dying of diabetes, then that's nothing. So ask when you get on the service, which, what do they cover? Some places have, like you said, massage, maybe they have help that comes in and volunteers. There are lots of different things, chaplain services, whatever. Ask what they offer. And then select the one that you want that's most aligned with what your needs are.
And it's sort of too bad that it has to be that way, but we have found, I mean, Centers for Medicare and Medicaid Services are who I believe sets the rules, right? And those rules should be applied to any agency that's billing Medicare for hospice, which they all are. But we have found when I first started, with East Pierce Fire and Rescue, it was 20 years ago, the only agencies in town that did hospice were Multicare Home and Hospice, Franciscan, and at the time Group Health had it just for their own insurers. Now, a lot of the home health agencies have gotten into the hospice market because they found that it can be profitable. But because of that, that standard of hospice care that the 2 or 3 agencies at one time held has shifted. And now, as Wanda's saying, you can find different quality of services offered and provided depending on what agency you're talking with. So, potentially shopping around for a hospice agency could be warranted, although that's unfortunate that we have to do that.
Well, I mean, yeah, but depending on the need at the time, I mean, obviously grief is an amazing factor of how urgency comes into play, just like when you pick out those end of the moments of funeral homes and such. They get you, that's where they go out and they get you a service. So when you're picking out your provider for your lower back, you pick these things. Sometimes you say, okay, we said you cover these things, but we don't necessarily know if they do or not.
Sure.
And again, like I said, we train on, I do it with the SHS, we know other people do it as well, their agency. But you don't know everything. So sometimes the information you give today is not the same information they give tomorrow.
Right.
So is there a process to appeal either to a different survey or to either shop to a different service at that point? Or
Yes.
can you turn around and find somebody else that give the answers? Maybe I don't want to give up on the service because you do a wonderful job, but we just need to have a different answer. Maybe you need to figure that out better.
I think there's almost always an appeal
There is,
process.
the original Medicare, they should, when they start the services, tell you who the original Medicare appeal administrator here is in the Northwest region instead of regionally. So they should have that information where you could contact them and say, hey, we got this.
To get more information,
Yeah.
clarity on what you're doing.
And you absolutely can change hospice provider as well. I mean, I've been involved in situations with patients in our district there where they just were not getting the service that they expected for their loved one, and they went to a different hospice provider that was able to do that.
So that's a great question. That's something I should research and add to the talk to have people know that there is a recourse there. Another group that administrates the benefit to understand what's covered, what's not. And then it's always severable too. So you could say, okay, I'm not happy with these services. I'm ending hospice care till we can just figure it out. So you're not locked into any modality as hospice care, nor are you locked in with that particular agency either. There's something happening, it's not comfortable. Okay, more information. Sorry for the small print here. It's like a script and a PowerPoint. Only your hospice doctor and your regular doctor, if you have one, considered by your terminally ill, have a life expectancy 6 months or less. You can get hospice care as long as the hospice medical director or hospice doctor recertifies at a face-to-face meeting that you're still terminally. So my experience with this, it really, again, it's a little fluctuating, sometimes they'll keep you on past that 6-month period. Some doctors are very hard stop and say, we need to get you back off hospice because you're not terminally ill anymore. It really is a judgment discussion you have with the family doctor more often than not. I don't know what your experience with that is, Jen, or what yours is.
People can be, I mean, it's not like if you haven't died by the 6-month mark, you're getting kicked off,
Yeah.
right? It is reevaluated and it can be a fluid process.
The nurses have to evaluate every month.
Oh,
do they?
So they keep, or say, graduate off. But sometimes too, your diagnosis for hospice, it's not necessarily your diagnosis that you think it would be. For example, my aunt hurt herself and her diagnosis ended up being malnutrition. because she wasn't eating, she was losing
Yeah, there
weight.
you go.
So it could
Yeah.
be something that, and if she starts to eat, then maybe that diagnosis is no longer appropriate. Maybe something else would work, and maybe it would. I'm gonna back up this a little bit, I want to say to encourage people to get on your palliative care or hospice way before you think you need it, if you have that option. Because if you wait until, they're going to die on Friday, nobody ever wants to call hospice early, because then you're giving up. But there's so much benefit you can get out of it. You can get the extra, somebody comes to the home, the nurse comes to the home, sometimes there are volunteers that come out. You get very personalized medical care from the hospice doctors. Maybe your doctor's a general doctor and he's great at curing you, but this thing is incurable. Maybe he doesn't know about that management or those other, the dementia that is affected by the bladder infection, maybe he's not so familiar with that. So if the earlier you get on, you settle some of those issues, you don't have those last minute crisis decisions.
I would, yeah, totally agree with that, because, and like anything, agencies have their own administrative processes too, so calling on Monday doesn't mean services start on Tuesday, right? It can be another week you wait. So yeah, the earlier the better when it comes to the options available to you once you are already started. So that's always great advice, appreciate that. Medicare won't cover any of these once your hospice benefit starts. So this is kind of where we're talking back to what you were referencing, treatment intended to cure your terminal illness and or related conditions. So again, a stark example of my uncle on dialysis, the dialysis ends. And so if he wanted to start the dialysis again, he would have had to say, okay, I'll stop hospice and go back on my dialysis. Okay, so terminal condition, treatment for that condition ends when you start hospice services. And again, we kind of made it out to say, it's not as stark as all that, because there's some gray areas where there are other things can go on for comfort care that might peripherally look like treatment for the condition, but it's really more management of the pain that goes along with the condition. Prescription drugs to cure your illness, those end rather than for symptom control or pain relief. So of medication for cancer, yeah, please come in.
I guess it depends on what you see as curing your illness.
Yeah, that's what I mean.
If you're diagnosed with cancer, they're not gonna pay for chemo.
Yeah.
But if you have COPD, they're still gonna pay for your inhalers.
Exactly, yeah, it's comfort in my view. To my view, if I always think comfort, it makes sense to say what's making the person most comfortable in this situation. So, yeah, I appreciate you chiming in on that. And so same with symptom control. I mean, people often report nausea from chemotherapy, radiation, all these different things, but the cancer can cause those symptoms. So it's kind of like, well, it's still a medication to treat nausea and enhance appetite, whatever the case might be, but it's no longer part of the secondary effect of the treatment. It's part of the underlying illness that's being tamed. So care from any hospice provider that wasn't set up by the hospice medical team. You must get hospice care from the provider you choose. All care that you get for your terminal illness must be given by or arranged by the hospice team. Worded really correctly, but basically means the hospice team should get the first call on managing things. Can't get the same type of hospice care from a different hospice provider unless you change to them. You can still see your regular doctor or nurse practitioner if you've chosen him or her to be the attending medical prevention professional who helps supervise your hospice care. So in my experience with home care services, yeah, that's exactly true, because the hospice services are going to be secondary to your regular treatment. In the care facility, it became a bit of a problem because, again, I'm not knocking them, but their view was maintaining life for my dad and mom. And our view was, no, we want comfortable end of life. And so it's a fine line to go between the two, because them being directed by hospice care when they're typically directed by their in-house doctor. So this is another discussion in terms of care facilities. You want to make sure you find from them how you guys handle working with hospice care teams. Some facilities do it better than others, but it can happen in assisted living, it can happen in an adult family home, skilled nursing facility, any care setting. Could have a hospice care. Room and board, Medicare doesn't cover room and board. If you get hospice care in your home, or if you live in a care facility, If the hospice team determines that you need short-term inpatient or respite care services, that can be arranged. Medicare will cover your stay at the facility with a small co-payment, possibly. Care you get as a hospital outpatient, like an emergency room, care you get as a hospital inpatient, on and on. Unless it's arranged by the hospice team, there might be some questions on coverage there. Always right, contact your hospice care team about these listed services where you may end up paying. So we always say hospice takes over, first call goes to the hospice team. There is a hospice care facility. I think the only one we have is University Place, or there are others in.
I don't know about others, that's regular.
Okay, so my uncle, different uncle, my uncle Sal, who was dying of leukemia. Late in his end of life situation, we actually talked to the doctor on Monday, because prior to Monday, the leukemia seemed like it was being held at bay with the treatment he was given. So he had done labs on Friday, we go in Monday, the doctor says, I'm sorry, the labs are worse than they were when we started. And again, this was after 90 days of what looked like steady improvement. He said there's nothing more we can do, there might be some experimental treatments you can do. And so I took my uncle home that day, and I said, Sal, I'll be back tomorrow. Show up the next day, call, knock on the door, can't, what the hell's going on? When I went back, doors were locked, so I actually had to break a window, get in. He was in bed, non-responsive, wasn't on hospice at that time. So I called 911, they came out, so we know he's terminally ill. I said, yeah, but I don't have the ability to take care of him here at home in this terrible crisis situation. They took him to the emergency room. He was vomiting, he had an intestinal blockage, all these terrible things. And so the emergency room doctor said, well, we can open him up and clear this blockage, but you do know he's already terminally ill. And I said, well, yeah, what can we do to keep him comfortable? Can we keep him comfortable here? And he was at St. Joseph's at the time. So fortunately, the doctor was able to call the hospice home in University Place, and our whole family lives in Fircrest, so we're very convenient, and we're able to get him from there to the hospice home. I think he was there 24 hours on pain management, mostly asleep during that time, and passed the next day. So that facility, so you work there, I don't know. So I think people have a misconception that people actually reside there, but it's mostly close to end of life when they're usually there. Am I wrong about that? Okay, great.
Generally, it's days to weeks. But again, if you have the opportunity to get them in a couple days earlier, it helps rather than last 12 hours. Obviously, you didn't know that.
Yeah.
But the sooner you can get them in when they qualify. And it's kind of like a little hotel room. So they've got a nursing staff there 24/7. They can have free medication. The family can come in and visit all the time. I think I've seen pets come in.
It's wonderful.
It's pretty
wonderful setting.
Yeah.
Lucky we have one. Beautiful setting.
Yeah.
Yeah, so that surprised me when they told me that one, because I thought, oh yeah, like you're saying, I wish I could have got it sooner. And I said, well, it's not unusual. The person comes in very late in the process, you know.
They also do that. We're talking about respite care.
Yeah.
And they'll have people up to a week per month. But, you know, depending on how long we have to.
Yeah.
So if the family needs a break.
Yeah.
They can go in there for a week and then come back out again. So again, it's not like you have to go in and never come out again.
Yeah, absolutely, yeah. And again, just talking about art rather than science, it was back in 2012, and I remember it was in January, there was like this horrendous snow and ice storm, roads were terrible. And so I kind of followed the ambulance, picked up my parents on the way there from the hospital in Fircrest, got them there and spent several hours there. And he was just sleeping peacefully, he wasn't in any pain. And even then, the doctor was like, well, based on his condition and what we're seeing, that he may live a couple more days, you know, and so it was like, my parents were elderly, it's like, okay, let me take you guys home. Not an hour passed, I got home, and the doctor called and said, no. So again, it's art versus science. Nobody really knows the situation when the exact moment's gonna occur. And then it's like, oh, we should have stayed an extra hour. We might have lived 3 more days. You just don't know. Okay.
And you have to give yourself grace.
Yeah, absolutely, you know, and I think the media, because of celebrities, we read about celebrities dying, and it's always written as, you know, he was surrounded by his friends and family. It's like, that's really hard to have friends and family there at the moment of death. I mean, it's very hard. It's physically taxing. People have jobs and families and all kinds of things, you know. I'm not knocking it if you can make it happen. But in my experience, that's a real difficult thing to pull off because it's just hard to be there at that moment. So like Jen said, give yourself a lot of grace on that because it's none of us know the moment, right?
Sometimes, I'm not new to it,
Yes.
sometimes people will, generally what they liked when they were living, they would like when they're dying.
Yes,
Wow.
excellent.
And maybe they want music, maybe they want quiet, maybe they wanna say goodbye to everybody, they don't wanna pass until you go out the door because they don't want you to be there.
Yes.
So again, kind of give yourself grace, it's like, maybe grandma was just waiting to be done.
It's a good point. It's an excellent point. There's a lot of magic and mystery that goes along with it. Whatever your faith foundation might be, there's a lot of mystery still in the world that we reside as humans. I throw the Walk Care Fund in here is because it's a new fund to pay for long-term care. It's not gonna pay for hospice or palliative care. If you've been working since July of 2023 in the state of Washington, there's been a mandatory payroll deduction to pay for this fund, to pay for your long-term care needs should you become ill or injured in your life. So we have information about this at our office if you need to know more. If you're currently actively working, we're the designated outlet for information in Orange County about this benefit. So let us know if you have questions about it, if you're actively working, if you have something. Yeah, exactly. Okay, legal documents to have in place for palliative and hospice care, like you were mentioning, early rather than late on these documents, and we do have a separate talk we gave this during the series about legal documents for decision making. Durable and durable power of attorney for financial and healthcare power of attorney form signed and notarized before care is needed. Because all of the things I'm going to talk about here have to be done while the person is awake, aware, and understanding the documents that they're signing. Okay, it doesn't do you any good with my uncle being conscious trying to figure out who's power of attorney, right? Advanced directive for healthcare, also known as living will, signed and notarized or witnessed. That basically provides the script back to that power of attorney for what end of life situations are going to look like. As an example, so like the example you gave, it would be nice to know what that person's desires were for those surroundings in some written form, because otherwise sister saying one thing, brother saying another thing, husband saying another thing. It's like, okay, she had different discussions with all of us. It could be 3 different things, right? And so it's nice to have it on paper to say, in my end of life situation, yeah, I would like to have candles, or I would like to have music playing. I'd like to have a favorite quilt or blanket on the bed with me, whatever the case might be. Otherwise, you're kind of floundering and kind of learning along the way. So you can just get by with powers of attorney, because that's kind of the minimum, but it's really nice to have the living will for other information about what my end of life situations. Post forms, physician order for life sustaining treatment. This is a document you get from the doctor. It's also known as a DNR form, and it's a discussion the doctor has to have with you and sign off about how your emergency medical services will look if you're typically an older adult or terminally ill. I'm gonna have Jen chime in on this because she's more of an expert on it. So
We actually just had a situation come up recently with confusion about the post. The post is really designed to give us instructions in 911 or 911 calls. And what confuses a lot of people is there's a part A and a part B, and people want to try and blend them. And part A is really just simply for when the person essentially has died. Natural death has occurred, they don't have a pulse, they're not breathing. Do they want CPR? Yes or no? That's it. Part B is for when they are still alive, but they have a potentially life-threatening medical condition going on. How do they want that treated? Full interventions, they want us to put a tube down their throat, deliver electricity to their heart if that's needed, or limited interventions, maybe just IV antibiotics, but not a tube down the throat, and then or comfort measures. What we have found in doing this is that, and in general, through my work, I have found that we as a culture don't deal with death very well. We don't talk about it enough. We don't talk about it openly. It's a big scary thing that happens hopefully on the other side of the room, right nowhere near us. And so as such, healthcare providers aren't always well skilled at having these conversations at the time the pulse is being given. And so we just had a patient who they had no CPR checked, but they had limited interventions selected, which really confused our providers because now she didn't have a pulse. And so it was like, okay, well, they want limited interventions, which can include electricity. So are we supposed to shock a shockable rhythm? No, because they said no CPR. But it's a very confusing combination that's unusual, but can happen because those conversations can be nuanced and don't always happen very clearly. So I think the easiest way that I try and help our providers understand it is part A is for when they have died, they don't have a pulse, they're not breathing. Part B is for when they are still alive and we're trying to make decisions about their care relative to what their wishes are. But these are very nuanced. They're difficult sometimes.
Yeah, so appreciate you chiming in. I know that you're an expert on that. You guys are the front line, most aware of what that looks like. We always tell people to have the form on the refrigerator, obvious place there, so it can be seen. So it looks like you brought yours along.
Versus with
Keep it in my purse.
That's good. And that's the other thing. It actually, I don't want to correct you, but it's actually now called the portable order for life sustaining treatment. And I think A, because it doesn't have to be a physician, it could be a nurse practitioner or whatever. But B, it also should go with the patient. So we tell people if we have to transport them and they have a pulse, we try to take a copy with us so that it can provide the emergency department those instructions. I mean, if they're going to admit the patient, they're going to develop another written plan for it in the hospital, but it provides that initial guidance to the emergency department team of what this individual wanted. So
was that when you met with your doctor? Did you
This
feel like
was
you could-
done in 2017.
2017.
It may or may not still be valid.
Yeah, well, and I was just thinking about that myself. And even before this, I do have the living will. We had a trust done, that was like in 2000. So yeah, I'm looking at this and wondering,
it should still be valid because they don't actually expire. It's just your wishes may have changed.
well,
in
exactly,
years.
yeah. And I know at the time my doctor, the medical condition patient goal is recovery. So I guess if I'm hoping that whoever's looking at me, if there's no way I'm gonna recover, then let's not go through full measures.
But
you
that's
know, I mean,
exactly asking them to do that.
Yeah,
So that might be worthwhile to have a second that with your doctor.
yeah,
family.
And more updated one.
yeah,
Yeah.
yeah,
And it might still be the same, but you want to make sure.
right.
There's a clarification.
Yeah, but yeah, I've always carried this in my purse. So I thought, I do have it, don't I?
That's good. That's
I
good.
figured it was good to bring it out.
And it's pretty well, in my experience, any encounter with urgent care, emergency room, that they typically, even a younger person, they're gonna ask you if you have a pulse form. Because
Yeah.
healthy situations can become terminal situations, you know, it happens, right? People go in for a routine knee surgery, and next thing you know, they're voting on the table. So there's a lot of reasons that, like you said, early better than late, right? You should have one for the most basic encounters with medical personnel.
And we have a whole session on legal documents that you can find the recording of on our website, where Matt really delves into this in a lot more detail.
Check that out. And there's some resources, I think, I put on the page about, you can get financial and healthcare power of attorney documents, living wills, whole packets about last will and testament, on a website called Washington Law Help. And we get summaries about what they mean, how to understand them. You can print them out. They're actual legal documents you can print out for free, fill those out, have them notarized, witness, whatever you need there. Last will and testament signed and notarized for witness in preparation, post-death, of course, you'll have to work death certificates. This bottom one is a big deal for me because we've encountered this constantly in our office. Make sure you and other trusted family members and professionals, such as your attorney and physician, have copies of these forms. Keep the originals in a known, secure place, okay? Power of attorney forms are no good if the people you've assigned to be your power of attorney don't have the documents. Living will is no good unless your family members have a copy of the document. Post form needs to be put or carried with you in a visible place at home. Again, last will and testament doesn't do any good that you've done one if it's in a box up in the attic somewhere, right? And we've actually had people attend this class who've been said to us that their attorney said, no, don't tell anyone. Don't tell anyone you're assigned the power of attorney. Don't tell anyone you've assigned them executor. That makes absolutely no sense to me, because someone has to take custody of those documents now and use them later, okay? So my view is, get all this stuff done early with the people in your family that are gonna be your powers of attorney, your executors, whatever the case might be. Have them aware of the documents, have them have a copy, you have the original in a secure place. That way, there's no questions later. So let me give you an example. I didn't put burial plan. But my parents, Catholics again, decided on cremation. The Catholic Church kind of changed its view on that. Different papal decrees that said cremation's okay. It used to be the body has to be buried without any damage to it. Instead of cremation, and that's changed, okay? So my parents surprisingly decided to do cremation burial plans. And so we went ahead and put the documents, took care of it, had it all filed off, and I had a copy. So the discussion came up with other family members once, and there were certain family members who were absolutely appalled and said, how dare you do this? Don't you know that's condemned by the Catholic Church? It's not. So go talk to the priest, whatever the case might be. So that discussion was hashed out before my parents died. Okay, so that was a good discussion to have. Different people had different views, but by the time discussion ended, that was the decision my parents had made. Now, you don't want that to happen after they die, to say, oh, by the way, mom and dad wanted cremation. I mean, good heavens, right? So my view is, you're either gonna have the arguments and disagreements when you're alive, and you can handle those, or they're gonna happen among siblings, children, whoever the case might be after you die. Better to have it done while everybody's around and able to talk about it than not. That's always my thoughts. Okay, and the resources. So our office is on there. You can always call us with questions, anything, you can look up on our website, all kinds of different resources and things. Put the Washington State Insurance Commissioner's link on there, because we're in Medicare open enrollment. They have a lot of good information about Medicare Advantage plans and D plans and things. WashingtonLawHelp.org, like I referenced on there, you can get legal documents on there. You can also set up for free, if you're 60 and over, your powers of attorney and living wills with an advisor from Dementia Legal Planning Project. That's a state-funded office that will actually come out and talk with you, or they'll handle it over the phone, through email and stuff like that, to set up those same documents for you. Talked about the Walk-Cares Fund a little bit, Medicare's phone number. Always remembering and reminding people in this last session, because we're heading into cold and flu season, all CDC recommended vaccines for older adults are now covered in full. No co-pays, including COVID-19, influenza, and pneumonia, shingles. Shingles is a big one, because that used to be co-pay required for that one. It's not anymore. Only thing I'll advise on this, different people react differently to vaccines. And so whether you've had a reaction or not, I always say, give yourself that next day in case you wake up and you feel terrible because you've had the vaccination. Don't have a lot planned for that next day. Give yourself a little grace there that next day if you have the vaccine. So, okay, that's the talk. Any questions, comments, anyone? Appreciate the dialogue along the way. It's been very useful for anybody sharing information.
Yeah, and if anybody has any questions online, feel free to raise your hand. And like I said, I can try to figure out how to allow you to unmute, or you can type questions in the chat. We do so appreciate everyone joining us today, both online and in person. They're such great sessions, and hopefully we will be able to continue them next year in some way, shape, or form.
And a couple notes, one, pain is not a given. Everybody always is afraid of pain. And a lot of times they're more anxious about the pain than the pain is there.
Good point.
So you can work yourself into anxiety. And you do medication for anxiety. So
That's true.
a lot of people die without experiencing or without using. Frequently it's given. It's like almost always there's a packet, end of life given in case at 2 a.m. on Saturday morning, you're having a baby. Generally, it would be in the home, but I wouldn't expect it necessarily. Certainly different diagnoses. Number two, make sure that your family is able to care for you. For example, maybe you want to die at home, but your spouse is 85 and not able to lift you.
Great point. Great point.
Things like that. Certainly, there are devices that can help. You can get a hospital bed, with things like that. Maybe your home is set up where you can do those things, maybe not. So again, ask your social worker, or if you're in the hospital, your discharge planner, those types of things. It might be better if you're in a facility. One thing for facilities, make sure that if there's a medication, if you're in a facility and the medication is given as needed, are you able to express yourself? Can you ask for it? Because maybe you can't. So maybe it's something that needs to, because they can't give it to you unless you ask for it. They can't look at you and see that you're in pain and give it to you. So you might want to have something scheduled rather than asking if pain is an issue or whatever the medication is. Which I lost my notes. Remember, you're in charge. You can start and stop at your desire. You can have medications, they may or may not be paid for, but you can still continue. If you want to be on 75 different types of vitamins, you can take 75 different types of vitamins. Last item, this was really a pet peeve for me because I had so many people who Friday, they were doing their own life care in their home, and then they maybe got lightheaded and fell, and then they're on hospice on Monday. Make sure you're taking care of yourself now. If, for example, you have blood pressure issues and you're on blood pressure medication and you lose weight, because that's the healthy thing, you want to take charge and lose some weight. Maybe your medication is no longer appropriate for you. Maybe you're too much medication and it should be cut back a little bit. Maybe you took a little more insulin, but you didn't eat as well that day. If you take care of those things, you might not end up in palliative care.
All good points.
So,
Thank you.
I just hated seeing that one.
It's an excellent point. Fall prevention, we do a lot of work around the county on fall prevention. We do a presentation about it. That's a big one. I think the number one reason that people as older adults end up in the ER, a lot of reasons, but having taken a fall, we all know people who've seen friends with black eyes because they fall and hit their face. So we do a whole presentation about that. So if you have a faith community group, civic group, any small group, church group, I'd love to come out and talk about fall prevention. We do a little talk on that. Dance with the coalition with me, events around town. You can go visit our website on Pierce County Falls Free.
I think so, Falls Free, Pierce County.
Falls Free, Pierce County, and lots of great information on there. We have a brochure in languages that you can print out about your folks, or give us a call at our office, send you out packs. Look at the brochures, bring it out person if need be. Love to help you out with that. And yes, it's great information too on the pain, because my mom, in those last few weeks, non-responsive, but there was no determination that she was in any pain, so we didn't have her on any kind of powerful medications or anything like that. And then again, understanding the process and what it looks like, that and at some point the body cannot absorb nutrition, cannot absorb hydration. So these are the things that in your living will you really want to have stipulated, that all you want is comfort at that point. But at some point, the hospice care nurse told us, your mom's in that late stage, so we're not going to hydrate it, not going to provide artificial nutrition anymore because the body's not needing that because it's shutting down. And then other family members kind of getting that information through a professional, kind of explaining that to them much better than I could. Because when I said, "Oh, we're stopping hydration and treatment," oh my gosh, she's going to starve to death, she's going to dry out. What are you doing to her? Well, it's all part of that dialogue of understanding what end of life processes look like. So please talk with your treatment teams, talk with your doctors, have those discussions way ahead of time. Visit Medicare.gov, get information on there. Call us, we can get you information about those processes, what they look like long before you need them. So.
Yeah, and you did bring up a really good point about the pain. I mean, my stepmom unfortunately had such significant pain, and no matter what the palliative care team did, they never were really able to get on top of her pain, but she also had a lot of anxiety, I think, about dying and about being in pain. And I think that they just sort of fed each other the pain, but the anxiety made the pain less tolerable. And it was just sort of this constant vicious cycle that, they were trying to manage pharmacologically and they just couldn't, which is why ultimately the decision was made to go to hospice. And then really just keep her sitting in until she died. But there's different ways to manage pain. Some people are able to have their pain managed through non-pharmacologic means. And so really a lot of it just has to do with the individual's approach, what they're open to, and how they're sort of thinking about their pain. So everyone is different.
points all. Thank you.
All right, I'm gonna stop the recording. We had one question in the chat, but it was more just differentiating, I think, our roles, which I've answered in the chat. If anybody else has any other questions, again, feel free to raise your hand or type into the chat. Not seeing anything right after that. I'm gonna pause the recording.